This presentation will give you some background on how and why we are asking women of childbearing age if they would like to be pregnant in the next year. Since this presentation was recorded, the nomenclature has changed. Instead of referring to a woman's reproductive life plan, we will be using the term preference moving forward. Every time the word plan is used, please keep in mind that the term preference is more culturally accepted with the general population. This presentation was recorded live in front of a nursing audience.
Hi everyone, and welcome to a Nursing CEU presentation for the Reproductive Life Plan. And today we're going to discuss this very new concept at DHS. And what it is it's a great way to really get some information about women of childbearing age to make a dent in the amount of unintended and unplanned pregnancies that we see in LA County. So my name is Dannelle Pietersz. I am a nurse practitioner. I work at Harbor, and I am here to bring you this information, so I hope you will enjoy this, this presentation. So what we're going to talk about today, some objectives are we're going to talk about what a reproductive life plan is, and we're going to discuss the importance of preconception health as well as contraception counseling. And we're also going to talk a little bit about the statistics of unplanned pregnancies in the U.S., and we're also going to name some questions that you could possibly ask, or the question that you can ask your patients in order to elicit this information. And we're going to also identify 3 different situations in nursing where maybe you would be able to provide this information. So basically a reproductive life plan, it isn't anything very technical. It's a very simple thing. It's a set of personal goals about either having children or not having children. And it's a plan to achieve these goals. And what we want to do is have women think about this plan, and we want to assess what their situation is because it makes a huge impact in the care that we give them. So what is a reproductive life plan? This isn't rocket science, you guys. It's basically just wanting to know from a patient, does she want to get pregnant, yes or no, and when would she like to get pregnant? It also has to do with planning for pregnancy and the interconception and the preconception period. We're going to talk about reproductive life preferences, and this information is not being asked right now. It's not being asked really across the country, but it's something that we need to start talking about, okay? Because a lot of women are planning to get pregnant, wanting to get pregnant, hoping to get pregnant, and not actually saying it because they don't think it's anybody's business, okay? But it's actually as providers and as nursing staff, it is very much our business because we want to know, do they have a medical condition, okay, that could affect the pregnancy? Are they on a teratogenic medication? Are they in a life situation where maybe they could hold off a little bit until certain things get put into place before they end up getting pregnant? So it's just this idea. So what does an RLP or a reproductive life plan represent? It just is basically, does a woman want to be pregnant or not want to be pregnant? Does she want to have children or not want to have children? And when could that possibly be? And it's really a dialogue between healthcare staff and women and really couples as well. And what this dialogue does is it opens doors for the healthcare services for prevention, for health promotion, for preconception planning, and as well to deliver contraception messages and contraception counseling. So why is this important? So just a few statistics for you. We know that in the US, about 50% of pregnancies are unintended. And the issue with this is about 22% of these unintended pregnancies are unintended births. And what happens is many times, and this is shown over and over again in public health literature, is that the babies and the moms of unintended births tend to have not so great outcomes in their physical health as well as their psychological health. Not all unintended pregnancies are a bad thing, but when you look at the entire population, especially the population of the US, we do see some negative outcomes from it. And I think what everybody wants is also to decrease the amount of elective abortions that occur in this country, and as well as maybe try to make a dent in the amount of early fetal losses if we can identify these pregnancies very early. What we want to do is get these numbers down, and we want this piece of the pie to get much bigger. And we think that we can help along that way by starting to actually have a dialogue with patients and not waiting till after the pregnancy test is positive. We understand is that there's a huge disparity in the amount of unintended pregnancies in the U.S. when it comes to race and ethnicity. As you can see in this slide, the amount of unintended pregnancies for African American and Hispanic women are much, much higher than they are for white and Asian women. However, even the numbers for white and Asian women are much higher, as you will see. So why does this happen? There's a million reasons, really. We hear a lot of different things from women, and what it comes down to is a lot of women have no idea when they're truly fertile. They don't understand sometimes how their contraception works. Their partners may not want to use a form of contraception. They may not want to use condoms. They may not think it's their fertile time. They may think it's God's will that they get pregnant. They don't believe in doing anything to get pregnant. Whatever the case is, it is. And what we really need to understand is what is the motivation for our patients, and we really also need to understand what their understanding is of their ability to get pregnant. But I want to get your attention to one of these, okay, which is the one on the green one over towards the right, where it says, my doctor said I couldn't get pregnant, okay? Say she's a diabetic and she has a hemoglobin A1C of 10, okay, which is really high. It should be, less than 6, less than 5.5, really, if you want to get pregnant. And she's got kidney damage, and she has problems with her heart, but she's of childbearing age, and the doctor says, you really can't get pregnant with your diabetes because it's out of control. What's the patient hearing?
That she cannot get pregnant.
Because her diabetes has made her infertile, right? So we really have to watch what we're saying to our patients. But what the clinician was saying is, please don't get pregnant. Your hemoglobin A1C is out of control. You will have a baby with a birth defect. Oh my God, your heart's going to be under a lot of stress, and so are your kidneys. That's not what our patients are hearing. Okay? So it's very important that we ask this question and we have this conversation up front in the intake. And this is one of the reasons that is very important. As you can see in this slide, most women, by 5 weeks of pregnancy, they're usually understanding that they're missing their period now. Maybe they think their period's a little bit late. Maybe they're not suspecting that they're pregnant. Maybe they're going to wait a few more weeks and see if they get a period next month. But the mean entry into prenatal care is about 12 weeks. And between 5 weeks when you first miss your period and 12 weeks, which is mean entry into prenatal care, two of the most important things for a fetus, and that's the central nervous system and the heart. And that's usually between 5 and 8 weeks. And so during this time that a woman doesn't know she's pregnant, she may be using drugs, drinking, smoking, and not realizing that she's pregnant. So by 7, 8 weeks, she's like, maybe I should go to the 99-cent store and get a pregnancy test, right? And then it's positive, and she's like, it's from the 99-cent store. It's probably not true. And you have no idea how many times I've heard this from patients. Especially for women who are pregnant, I want to know what's on their mind the first day that they're sitting there naked and I'm going to be doing, an exam for them, okay? And what they say to me is, well, I'm here for my prenatal vitamins and to see my baby. So what are her priorities? She thinks that the prenatal vitamins are going to make everything okay. It's 12 weeks already, all right? Damage has been done if it's going to be done, all right? And the second thing is she wants to see if her baby's okay. She wants an ultrasound. Okay, she doesn't care that I'm going to order a battery of tests. Okay, she doesn't care that we're going to sit and talk about, the development of the child and the pregnancy and how things are going to go and what prenatal care is going to be like. And, I'm going to start the process. I'm going to do her physical. And she doesn't care about any of that. Okay, so again, this is my experience. And so it's very important for us to diagnose pregnancy early. And it's very important for women to realize that the first few weeks of pregnancy are incredibly important, especially to avoid any type of birth defect. So let's talk a little bit about infant mortality. These are California's infant mortality rates. In the last 100 years, there's been a huge decrease in the amount of babies that die within the first year of life. That is a huge public health coup for us. However, let me tell you what's going on right now. So as you can see in this slide, that the US and even California does a lot worse as far as infant mortality is concerned compared to other countries, including other countries that have gross domestic products that are very similar to ours, such as Japan and France, a lot of countries in Europe and things like that. And you can see that we often use infant mortality rates as a way to gauge the health of a nation. And if you look at the slide, you can see that the US isn't really doing that great. And we're not that great, even though we have this amazing country and we have amazing services. Not everybody gets access to them. And then other things that really jump out at you is the fact that there are disparities within race and ethnic backgrounds as well. And you can see that there's a huge disparity in the amount of infant deaths that occur with African American babies as opposed to white and Hispanic babies. But even the numbers for white and Hispanic babies are not that great when you compare us to other countries. So it's really important for us to recognize this, and we need to actively do something about this. Look at how many more black babies die than white babies. And those numbers are not that great either when you take a look at the rest of the world, the rest of the Western countries that have gross domestic products that are similar to what we produce. These numbers are horrendous and they need to be addressed. Now, these are also reflected nationally, and the numbers in the South are much higher than in California. And so let's talk a little bit about the amount of deaths that occur with moms during the 45 days after delivery of a child or during pregnancy, and also the health conditions that crop up during pregnancy. And as you can see, we see another huge disparity with African American women as opposed to Asian, Hispanic, and white women, where there are way more African American moms that die because of something related to childbirth and pregnancy. And again, this is something that needs to be addressed. And if you look at maternal morbidities, I've picked 3 very common ones, such as hypertension, diabetes, and asthma. And what this graph shows you is that more and more women are entering prenatal care already sick, already with a morbidity that can affect not only them, but now you add a pregnancy to that situation and it can make the pregnancy also not go very well. And so what can LA County nurses do about this? Okay, well, there is one key question that we can all ask, and it's a very simple question, and it's been written into ORCID, and I'll show you how that goes. The question is, are you or your partner seeking to be pregnant within the next year? Okay, and what it does is it's really part of this comprehensive strategy for nursing, and the goal really is to improve birth outcomes. And it's also a teachable moment for us to clarify pregnancy intention with our patients. We really want to incorporate the reproductive life plan question into our daily nursing practice with intake. It is a part of a comprehensive strategy. Now, I know I'm speaking to the converted because you guys are OBGYN. Peds, I'm so glad you guys are here, the Hub Clinic. But I really need to do this for the primary care patients and the specialty care, okay? Because women of childbearing age, a woman who's 32 and who has diabetes has got to be treated differently than a man who's 32 and has diabetes, because she can get pregnant, okay? So it's very important for us to understand that there is this thing called gender-based medicine. We have to understand the difference between men and women that way. And why should nursing ask about the reproductive life plan? Really, it's a starting point for ongoing education about general health as well as reproductive health. And so what we want to do is we want to assist with intention and timing. We want to assist with preconception counseling. We want to screen for potential risks. By asking this question, we want to promote health, and we also want to help with the treatment of existing conditions before the patient gets pregnant. And really, asking this reproductive life plan question while you're taking your vitals and getting their weight and everything and getting their LNP, it's really it's a great teachable moment for us to clarify pregnancy intention so that the clinicians can use this information to counsel their patients. We've built into the ad hoc form for ORCID, and so nurses, you would go to the ambulatory quick intake, and after you do your vital signs and your pain assessment, you come to the reproductive life plan question. And here we have that question, and it's very simple. Are you or your partner seeking to be pregnant in the next year? And if the answer is yes, then the next 2 questions blank out. Actually, you don't have to ask about their contraception, and then you go on to ask about the last menstrual period. And so if their menstrual period has been, say, 30 days prior to the day that you're asking this question, it's very important that we do a pregnancy test if there's a chance that she's having unprotected sex and is eagerly wanting to get pregnant. If the answer is no in the reproductive life plan question, you can see that you have an option of every birth control method that is acceptable and that's also approved by the FDA. And you can ask the patient what birth control method they are using to actively not become pregnant. And then also ask them if they have unprotected sex within the last month. So if they're using a birth control method that's not a high-ranking method, such as, say, the withdrawal method or occasional condom use, and they've had unprotected sex in the last month, if they're getting close to missing their period, then it's a chance, or if they've missed their period or about to get their period and haven't, it's a good time to do a pregnancy test before they see their clinician. And it's also a good time to give them some information about birth control methods. Okay? So then after the LMP, after you get the pap and mammogram, then ask the question, and you can ask it any way you want. Are you or your partner planning on getting pregnant in the next year? We don't want some way off idea, and we don't want to know if they want to get pregnant right now. We want like a reasonable period of time, and a year seems to be what seems to be working, okay? And then if the answer is yes, they want to be pregnant, then the bottom part right here, it says where you're currently using contraception, grays out, okay? If they say no, then it lights up and you have to ask that question. And then you also want to ask, have you had unprotected sex in the last month? Because if her LMP was 29, 31 days ago, what do you want to do, right? You want to collect her urine, okay? Because you want to be able to diagnose it ASAP. So that's why it's all kind of put right there. So the reproductive life plan question is for all women of childbearing age. And what I really want primary care and specialty care to do is when they huddle in the morning, is to take a look at their list. Say there's 30 patients for that clinician that day or whatever. Look at the genders and the ages. So just forget about the men for right now, okay? And look at the women, and then look at the women who are under 52. And if you add up that number, it might be 3 or 4 patients for the entire day if you're doing a PCMH clinic or a specialty clinic. So it's really not that many people to ask, okay? Let's say you're uncomfortable asking this question. Here's a way you can ask this question. You can say, in order to make sure that we can provide as many services for you as possible, we're asking all women specific questions that relate to their desire to become pregnant. If you don't want to answer the next 2 questions, please let me know. Give the patient an out. To be honest with you, I ask this all the time in my clinical duties, and never once have I had a patient tell me that's none of my business. Basically, I'm their healthcare provider. I'm their nurse, and so this is very much an appropriate question, especially if you give them a reason why you're asking the question. And these are the 3 questions that you would ask. Would you or your partner like to become pregnant in the next year? What are you using to prevent from getting pregnant? And have you had sex without using a method of birth control in the last month? And here's another way you can ask this question. We have a new policy here at our clinic that we ask all women under the age of 52 if they are planning on getting pregnant. If you don't want to answer these questions, that's okay. Most women will have no problem, like I said before, answering this question. And we want to use the ages of 15 to 52. We want to recognize that some teens may be trying to get pregnant or wanting to get pregnant. And some older women, over the age of 40 or 45 may also be wanting to get pregnant. So we've used 52 because that's the average age of menopause in this country. And so really we want to recognize that there's gender-based care. So a 36-year-old woman who comes in with diabetes should be treated very differently than a 36-year-old man with diabetes, because a 36-year-old woman can still get pregnant even if she's had 3 children before. Okay, and it may appear to you that she's done with her childbearing, but we don't know that for sure until we actually ask it. Okay, if you feel uncomfortable asking the question, you can give them an out. Okay, and most of the time they're not going to take the out; they'll just answer, because you have a right to ask this question. You're not their accountant. You're not their mechanic, right? It'd be kind of weird if I took my car in and somebody asked me this question. So and almost always I preference it with, I really want to make sure that I get all the right tests and do everything I can for you, so I really need to know what your intentions are, so I don't miss something, is the way I say it. Okay. So what if the answer is yes? Okay, so the thing with this question is there's no wrong answer. So you want to say, hey, that's great. I'm so glad you told me. It's always best to prepare for pregnancy. Okay, it's important that you talk to your provider so that if you need any medications, if the medications that you're taking or your medical condition does not harm your pregnancy, okay? And can I give you some information about how to have a safe pregnancy? So this is a great way for you to really assess whether, if, for example, if she's coming in for diabetes and her diabetes is out of control, she may not have said this to you that she wants to get pregnant unless you asked her. And now that you've asked her, and the answer is yes, then we can take that into consideration as we are dealing with her diabetes. And so really what we want to do when the answer is yes is we want to start thinking about preconception care and preparation for pregnancy. We want to identify whatever medical conditions she has. We want to make sure that she's taking her folic acid or her folate, making sure she's eating her green leafy vegetables, avoiding alcohol and drugs now while she's trying to get pregnant. And we want to make sure and encourage her to be in healthy weight. We can talk to her about nutrition and exercise. And we also want to make sure she's not on any teratogenic medications already, because we might need to change those medications if she's actively trying to get pregnant. So just a quick note about pharmacology. I know most of you got this in nursing school, but I just want to remind you there are several categories of medications, and the FDA pregnancy categories go from A to D, and of course category X. Category A and B are pretty much safe to take during pregnancy or before pregnancy, and category C, D, and X medications are not safe to take, and especially we know that category X medications does cause birth defects. So if you have a patient on a category X medication coming into your specialty clinic and she's a woman of childbearing age, we really, really need to know her pregnancy intention, and we need to let her know that the medication that she's taking is a teratogen, because so many women may not know that. I just want to remind everybody the categories of the medications. These categories are actually going away. Okay, so all the new drugs that are approved by the FDA, I think as of like last July or something like that, won't have a category. It will actually have a little blurb about preconception and about pregnancy, and it'll summarize what it's supposed to say. But all the old drugs will still have the categories in it. So the best thing to do is, if you haven't thought about this, is to try to look up the category of the medications that you're giving your patients now, just to refresh your memory, okay? So if your nurse does tell you, clinicians, you know, that she is having unprotected sex, wants to get pregnant now, that could be something for discussion. So let's talk about some medical conditions. And I'm sure you all know that these medical conditions can adversely affect a pregnancy: diabetes, hypertension, heart conditions, seizure disorders, thyroid conditions, obesity. Some of them are associated with low birth weight and prematurity. Some of them are associated with teratogens as well. As far as diabetes, hypertension, heart conditions, seizure disorders in particular, because a lot of category X medications are given for seizure disorders, and thyroid, you know, hyperthyroid can be very, very dangerous, and obesity as well. So they're just things that we need to discuss. And then things to consider, obviously, lifestyle choices. We all know this. We all know that you shouldn't be smoking and drinking alcohol, or God forbid, doing any type of street drugs while you're actively trying to get pregnant, or while you're pregnant. But a lot of women may not realize that you really shouldn't be doing this while you're actively trying to get pregnant as well. And it's a good idea to maybe cease especially smoking and alcohol while you are trying to get pregnant, so that when your pregnancy test is positive, there is no alcohol, there is no tobacco already in your system. Okay, and as you can see on the slides, these are some of the side effects of alcohol and tobacco, which I'm not going to go into detail because I'm sure we're all familiar with this. A lot of women are motivated to quit smoking after they find out they're pregnant. But we really do need to have this discussion ahead of time because of the secondhand smoke. We don't want the baby exposed to any secondhand smoke. And we really want to help them with their smoking cessation beforehand. I'm not saying this is easy, but it's a discussion that we really do need to start having. And of course, healthy weight is also very important. There's issues with obesity, and there's issues with being underweight as well for pregnancy, and the nutrition that the women might be getting, and other conditions that are associated with adverse outcomes in pregnancy as far as obesity and being underweight are concerned. This is a great way to, motivate women to get a little bit more exercise, to eat a little bit more fruits and vegetables, and maybe less sodas and less sugar and less fast foods, because when women let me know that they want to get pregnant, it's a great opportunity for me to talk to them about how important exercise is and how important it is to eat, the fresh fruits and vegetables, because the bottom line is they should be taking their prenatal vitamins and folic acid before they get pregnant. It's best to take it at least 6 months before, even a year before. There's a lot of evidence that shows that women who had high folate levels before they got pregnant and during pregnancy, their children, when they grow up, have less heart problems. And then let's talk about preparing for pregnancy. So one of the few things that we can actually do is we can talk to women who are interested or would have a desire to get pregnant in the next year, is at least talk to them about taking folic acid or eating their folate from natural products that have the B vitamin. Folate occurs naturally in green leafy vegetables and colorful things. So we want to encourage women to eat things that naturally grow out of the earth, that don't have any artificial colors, like your red bell peppers and your green spinach and your yellow bananas and things like that. But folic acid is in prenatal vitamins, yes, and you can take a supplement of folic acid, but what we really want is for women to get their folate naturally and then take a supplement as well. So it's a good idea to start taking your folic acid before you get pregnant. Actually, research shows that you really need to have it on board for about 3 to 6 months before you get pregnant, because once that neural tube has already formed within really the first 8 weeks of life, the folic acid isn't going to do much if you take it after that. Okay, and very, very few women know that. You should be getting your folic acid from what? Your green leafy vegetables. I hate to say it, but that's where the folic acid is. Okay, it's in those green leafy vegetables. It's in all the colorful foods. And I'm not talking about Cheetos, right? I'm talking about yellow bell peppers and orange carrots and green spinach and whatever, all the foods that have color to them. And just to show you, here are some of the statistics of women that have taken folic acid for the month before their pregnancy. As you can see, the older the woman is, the more likely they're going to take it, but really only about 44% of women who are 35 and over are taking folic acid before they get pregnant. And that number is so low in the 15 to 19-year-olds, where only about 20% are taking any type of folic acid before pregnancy. So it's important for us to remind women that we should have them take their folic acid, be increasing their folate in their regular food consumption before they get pregnant. So what if the answer is no? What if they don't want to get pregnant? That's correct as well. So you say, okay, great. What are you using to prevent pregnancy? And then ask her and let her answer. And then you can also, here's a teachable moment. You can also let her know, did you know we offer all birth control methods here? Would you like some information about all the different methods? And most women have no idea about all the different methods that are available. And I would recommend that you use a really easy one-page pictorial like the one that you're seeing on screen right now. And this is done by the CDC, and this is called the tiered effectiveness chart. And what this does is it shows all the FDA-approved methods from the most effective to the least effective. As you can see in the chart, the most effective that are not the permanent methods are what we call the LARCs, or the long-acting reversible methods, the implant and the several IUDs we have. And those are methods that are really where the clinician does all the work and the patient doesn't have to do anything until they want it removed, until they want to get pregnant, or want it rechanged or updated if the method is wearing out, so that they can continue to have a really great method of birth control. And then you can see the second tier methods are the ones that are dependent on the patient taking them themselves, and the effectivity of these methods go down depending on whether the patient is correctly using the method. And then, of course, there's the third tier methods, which have about an 80% effectivity rate. They're certainly better than nothing, but you have a much higher chance of not using one while you're having sex if it's not available to you. If you do nothing other than just put this in front of the patient's face and say, hey, we have all these methods of birth control here. You just need to ask me, okay? Or if you're in pediatrics or another clinic, you can say our women's health clinic has all these methods here available. So it's just a little advertisement, okay, to get them to start thinking, and then you can make that appointment if need be with women's health, okay? And the thing is, I like this because it's one piece of paper, it's mostly pictures, It's the most effective is on the top, the least effective is on the bottom, okay? And that's really the best way to catch somebody's attention. And every time I bring this out, I notice my patients' eyes and they go directly to it because they're interested. They're like, oh, what's that? You know, and hopefully they're not looking at the withdrawal because the people are having sex. But I just want to take a minute to address withdrawal, okay? It is a birth control method. You can see it's not a great method, but it's not that much different from using condoms if you're not using condoms correctly, okay? Because condoms can break. I'm not discouraging anybody to use condoms. Is that clear? So withdrawal is a method that a lot of people use so when you're asking the patient, have you used anything or what have you been using to prevent pregnancy? And if the patient says nothing, okay, then what you want to do is you want to say the words, okay? Does he come out, does he ejaculate outside of you, okay, or does he pull out? And then almost always, a lot of times a woman who answers no to the question, the one key question, will say, well, yeah, you know. So you want to say, okay, well, you're using a method. That's your method of birth control because it is a legitimate method of birth control. It's not great. Here's your opportunity to go, oh, okay, well, it looks like you're using a method, but these ones are more effective. How serious are you about not getting pregnant? Because if she's really serious about not getting pregnant, you just have her attention. And you can be like, oh, you mean he doesn't have to pull out if I use something like up here? Okay. And here's a chance for you to introduce implants and IUDs to the patient, okay, and then move on to introduce the other ones. And to be honest with you, the way I like to use this chart in my 2-minute counseling session is I like to say, well, she might tell you, well, I want to have another baby in 5 years or in 3 years or whatever, or not right now. So I go, okay, well, let's not talk about the permanent methods. Let's just forget about that for now. These methods are all, the rest of them are all reversible. These two up here, I do the work for you, okay? Or you, as nurses, you guys can say the clinicians do the work for you, and then you don't have to do anything. So what am I doing? I'm actually, I'm applying to her laziness because Lord knows I am, all right? I've got plenty of things to do. The last thing I need to think about is my birth control, okay? So that way, okay, the idea is, oh, you mean you can do something and I don't have to worry about it? And I say, I do the work for you and you can have all the sex you want. When you're ready to get pregnant, you come see me. It'll take me a minute to take these out. No big deal. And you can get pregnant right away. And then for the second row, I say, these methods are a little less effective, but you're in control of these. So now I'm kind of reaching to the women that like to have control in their life. Because I've had women say, I don't like the idea of an IUD being inside me. I don't know what's happening. If I take a pill every day, I know I'm in control of that and I know I won't get pregnant. I totally have to respect that type of personality, okay? So I'm giving them that choice. Do you want to do something every day, every 3 months, once a week, once a month, when you have sex? It's up to you, okay? And now it's really, truly up to her. It's like what sounds good to her, okay? So I use this that way in a very quick and dirty way of just saying, hey, think about it. I just want to take a minute to talk about long-acting reversible contraception, or LARCs. As most of you know, we have an implant that lasts for 3 years, and it goes in a woman's arm. And it's a very easy, it just takes a few seconds really to put in. It's almost like an injection. You can't see it, but you can feel it. It lasts, again, for 3 years. It has a safe hormone in it, progesterone. Just about everybody can use it. And then there's also 3 IUDs out on the market. There's the copper IUD, which has no hormones at all. It's great for women that don't like to use hormones. It lasts for 10 to 12 years. It's easily inserted, easily taken out. And then there's the 2 hormonal IUDs. The top one is the Mirena, and it lasts for 5 years. It has a little bit of, again, progesterone, a safe hormone. And then there's the Skyla, which is slightly smaller, and it has progesterone as well in it, and again, it's good for 3 years. These methods are very easy to put in, very easy to take out, and All 4 methods, once you take them out, they are quickly reversible. Therefore, you can get pregnant within 2 to 4 weeks. So they have no long-term effects and are very safe for a lot of women. And they're especially safe for a lot of women who have a lot of chronic conditions. So what if she's not having sex? You can say, okay, I just wanted to let you know that we have all the available birth control methods here. If you need something in the future, you can always come see us. Or if you're planning on getting pregnant in the future, it's a good idea to come talk to your doctor first so that maybe we can do a physical and see if there's any conditions that might harm you or the pregnancy in the future. So really some daily opportunities to discuss reproductive life planning. It's there in the ambulatory clinic every day. Your diabetics, your hypertension patients, your seizure disorder patients, anybody who's changing medications before they might get pregnant. It's important for us to assess what medications that they're taking. For example, in the NICU, nurses spend a lot of time with couples that have just had a baby. So it's really important to know if they're using a method so that she doesn't get pregnant right away again, because she may or may not be breastfeeding. It may be very difficult to breastfeed if you've got a baby in the NICU. And of course, pediatric nurses too, when couples or moms bring their newborns in for their first immunizations, this might be a way to bring up that we have these services here and encourage these women, these moms, to go see their OBGYN or their family practice doctor to make sure that they get a birth control method. So let's do a couple of patient scenarios very quickly. Is Anna. She's 34 years old. She's had 3 pregnancies, 2 children, and she's had a miscarriage. She's coming into your diabetes clinic. She's overweight. She has hypertension. She was diagnosed with diabetes about 3 months ago, and she's coming into her patient center medical home clinic for a 3-month follow-up on her diabetes and a refill on her medication. She's on her meds, and as you can see, her vital signs are a little bit off. She has a BMI of 29, and her blood pressure is a little bit elevated, and she has a random blood sugar that's high as well. So obviously she hasn't gotten the hang of controlling her diabetes, and maybe her medication that she's taking for her blood pressure isn't working. But it's important to take a look at her medications. So the hydrochlorothiazide and the glucophage she's on, she can probably take when she's pregnant, but really the enalapril is a category C medication, and she should not be taking that if she wants to get pregnant. So you're doing her vitals and you're asking her the question, would you, your partner, like to be pregnant in the next year? And she says something to you like, well, I didn't think I was going to have any more children because I have 2 kids, but I got divorced a couple of years ago and I have a new partner and he doesn't have any children, so he would like to have a child and I would like to have a child with him, but I'm not sure if it's the right time. So she's giving you several different types of messages here, and we need to recognize that. Hi Anna, how are you today?
I'm okay. How about you?
I'm good, thanks. So you're here for a follow-up on your diabetes. It looks like it's been 3 months since we started you on the medication. I just need to take your blood pressure and weight. And also, can you tell me when your last period was?
My period finished about 5 days ago. Oh, and also, before I forget, I'm almost out of my diabetes medication.
Yeah, no problem. We'll get that refill for you. But one thing I wanted to ask you today as I'm looking over your medical history form is that we need to know if you'd like to get pregnant in the next year or so.
Why do you want to know that?
Well, the reason is that you're only 34 years old, and since you have diabetes, it's important that we know what your plans are for having children. We want to ask everybody under 52 this question because if you do want to get pregnant, it's important for you to plan for it, especially if you have a condition that may affect your pregnancy. Like, for example, in your case, did you know that high blood sugar can cause birth defects?
Really? I didn't know that.
Yeah, it actually can. And also, do you have any kids right now?
Yes, I have 2.
Well, would you like to have any more?
Well, I didn't think I wanted to because my youngest is 7. And honestly, I can't right now. With work and taking care of my kids. My ex-husband's no help at all. But my boyfriend, he has no kids. And he'll like to have at least 1 child,
So it sounds like what you're telling me is you don't want to get pregnant right now, but you may want to have another baby in the near future. Am I hearing you correctly?
Well, yeah, my boyfriend, he's 5 years younger than me, and he really wants to be a dad. He loves my kids, and all that, but you know how it is with men.
Yeah, I can understand that. I'm glad you told me because it's really important that you not get pregnant until it's best for you. So what I really want you to do is speak with your clinician today about your blood sugar results, and let's get your diabetes under control before you have unprotected sex and get pregnant. By the way, what are you and your partner using to avoid getting pregnant right now?
Well, we use condoms sometimes.
Oh, really? Okay. And then the rest of the time?
Well, the rest of the times he actually takes care of me.
Oh, so do you mean he pulls out?
Yeah, but sometimes I really think he doesn't want to do that.
Well, it sounds like you're making an effort not to get pregnant right now, which is good as your diabetes is not quite controlled just yet. And you're taking a medication that could be harmful to a pregnancy, so you may want to consider not to get pregnant right now. That will give you some time to get your diabetes under control, and your clinician can switch you to a medication that's safer for you to take with pregnancy. Then you guys can get pregnant with less risk to your baby.
So how do I do that?
Well, I'm not sure if you're aware of all the different birth control methods we have out there, but as you can see, this chart gives you an idea of all the methods that you can use. If you'd like, I can make you an appointment with our women's health clinic to come back and discuss using a method until you're ready to get pregnant. There are some methods that are 99% effective, like the IUD and the implant, but the nice thing is you can get pregnant very soon after they're removed. What other methods have you used in the past?
Well, I have only used condoms and the shot before, and I did not like the shot at all. And I know I won't remember to take the pill every day. My life is too hectic for that. I'm sure I'll forget.
That's okay. As you can see, you've got all kinds of options here.
I didn't know there were so many options.
Yeah, there are, and we have all of them available at this facility. But another thing I wanted to let you know about is that since you might want to have another baby in the future, it's never too early to start taking your folic acid, which can really help prevent birth defects. You can take it in the form of a prenatal vitamin, and it's really, honestly, it's best to take it before you get pregnant. So if you start your folic acid now and then decide to get pregnant in the next year or so, you will be even better prepared. And don't forget, exercise and a healthier diet will not only help control your diabetes, but it'll also be good for your body in general, which will be good for a pregnancy in the future.
No one has ever told me any of this before. Thank you. It gives me a lot to think about. And it'll be nice to have another baby because my son is such a big boy now.
Okay, well, great. Here's a brochure about birth control options I showed you, and here's one on how to prepare for a healthy pregnancy. So let's get you in the exam room, and I'll make you an appointment at our women's health clinic. I can give you the appointment before you're ready to leave today.
Okay, yeah, I like that.
Okay, great. Come with me. So one way of rephrasing what she's saying is, so I hear you're saying your boyfriend wants you to have a baby right now, but you're not so sure. Do I have that right? You can use some motivational interviewing type techniques. Or it sounds like you may want to have another baby too, but you're not sure if it's the right time. Is that what you're trying to say? And then let her have that conversation with you, because this is a really good example of someone that may need more than one type of education from you. So we want to clarify how motivated she is to become pregnant or not become pregnant. So she has some desire to become pregnant, but maybe right now is not the right time. Maybe in a year or so it would be better. So you want to discuss the appropriate interventions with her. So in her case, she may need some contraception to get her through the next 6 months or the next year while you negotiate with her how important it is for her to get her blood pressure under control, for her to get her diabetes under control and her blood sugar under control, because she may not understand that high blood sugar is a teratogen, okay, and can cause some severe birth defects. So she may need some contraception, but it may be a very short-term contraception. But at the same time, she may need some preconception care also. So her preconception care would be talking to her about how important it is to control her diabetes, how important it is to control her blood pressure, and even maybe do something about her weight, which can actually help control her blood pressure and her diabetes. And so she not only needs a preconception message, she also needs a contraception message. So it's not necessarily always one thing or another. And the important thing to understand is that ambivalence is almost always there with most of us and with most of our patients, and we just need to recognize it and work with our patients. So let's go on to our second patient. This is Tamika. She's 42 years old. She's a gravid of 5, parent 3. She's had 2 miscarriages. She's coming to you in nephrology clinic today to start dialysis. Okay, she's only 42 and she's starting dialysis because she's had lupus for over 10 years and her lupus has affected her kidneys and she needs a kidney transplant. She's on the list, but while she's waiting, she knows she's got to get through her dialysis. So she's on some pretty serious medications that suppress her immune system. And these medications are a category D and a category C medication. So does she know this? Does she not know this? This is important. And she's only 42. She's got maybe 8 years, maybe 10 more years of fertility left. And I think it's important that we recognize this. Good morning, Tamika. How are you?
I'm good, just here for my regular visit, just waiting to see if I get any news on a kidney transplant.
Yes. Well, I hope that happens soon. But in the meantime, let's get you set up for dialysis. Are you still taking your cyclophosphamide and your steroid?
Yes.
Okay, well, let me take your blood pressure. Okay, and I also need to know, when was your last menstrual period?
It was a month ago. I should be starting again in a few days.
Okay, great. Let me put that into the computer and figure out the date. Okay, also, I need to ask you a couple of questions that we're now asking all women under 52. Since you're 42 and still having periods, we need to know if you or your partner are planning on having any more children.
Good heavens, no. I am too old for that. My kids are grown, and I finally got them out of the house. Plus, they said I can't get pregnant because of my kidney condition.
Oh, okay. Well, it sounds like you're done with that part of your life. But to be honest with you, if you're having periods, you're still young enough to get pregnant. And you know what? You are absolutely right. It would be dangerous for you to get pregnant right now because of your kidney problem. And also it would be really dangerous for a pregnancy because of the meds that you're taking. So tell me, what are you and your partner using to prevent from getting pregnant?
We've been using condoms, but sometimes he gets lazy and doesn't. I'm not worried about it because aren't I close to menopause?
Well, actually, most women don't go through the change until they're in their early 50s. So you may have 10 more years of needing to use something to stop from getting pregnant. Do you think you and your partner will be okay using condoms all the time for the next 10 years?
Really? 10 years? Oh.
Yeah, and I don't know if you're aware, but there are all these methods available for birth control for you. Some of them last a long time and some are permanent. Then you guys won't have to think about using condoms anymore. For example, these IUDs and implants, the clinician places them in your arm or your uterus and they last from 3 to 10 years. Of course, depending on which one you choose.
Huh. And I thought there were only pills and condoms. And I didn't think that I could take the pills. I like the idea of my husband getting fixed, but you know how men are. I like this IUD thing.
Okay, well, let me make you an appointment with our Women's Health Clinic before you leave today. They can give you more information about IUDs, and they could also figure out what's best for you, especially with your kidney disease. They place IUDs all the time, so you'll be in good hands. You can always use an IUD until your husband decides if he wants to get a vasectomy or not.
Okay, thanks for the information. I really thought I was too old to get pregnant.
So what you want to do is kind of draw her out a little bit and say, it sounds like on the one hand you understand how important it is that you don't get pregnant, and yet since he doesn't use condoms all the time, maybe you may be at risk for an accidental pregnancy. How would you feel if you found out you were pregnant now? And then pause, okay, for an answer and let her answer you. And if she says, oh my gosh, that would not be a good thing, then here's your opportunity to say, gosh, did you know there's all kinds of other methods that you can use? And you can use certain hormones under certain conditions. And we'd love to make an appointment with you so that you can go to the GYN clinic and get further counseling. And here's some information, okay, that we can give you. For women on dialysis, the Mirena IUD is actually excellent because it helps them with their, when you have kidney failure, it helps them with their anemia. because that's a side effect that they have. She can have the Paragard IUD. There are other methods of birth control she can use. And also you might want to, and she's telling you she doesn't want to have any more children, you might want to also discuss her getting her tubes tied or her tubes occluded with the Assure. And you might also want to bring up the fact that maybe her husband wants to go get a vasectomy so she doesn't have to worry about this. So there's really a lot of conversation you can have with her in a very short period of time. And she may be very thankful because nobody's ever told her that, because all her doctors have ever said was, use a condom, don't get pregnant, okay? And here, this is kind of a hassle for her in a way, because she wants to have sex. She has a normal sex life with her husband, and wouldn't it be nice to take a little bit of that stress off? You want to do some shared decision making. You don't want to be talking at your patients. You want to focus on what her preferences are, what works in her lifestyle, and help her support her decision without any pressure. And we really want to, and shared decision making really is associated with improved satisfaction with counseling and with the choice of method that the patients take. And be prepared for all of your patients, and I've said this before, to be ambivalent about what they want to do and whether they want to have a child or whether they not want to have a child, and that's okay. It's totally normal. And so the important thing is to try to give some positive feedback. In Tamika's case, I would say, well, you're obviously very smart. You know what you need to do. You understand, you take your doctor's advice. You understand how important it is to protect your kidneys by not getting pregnant. Okay, and then say, let me see if there's anything else I can help you with. Okay, or you've clearly thought about this a lot. So what do you make of the situation? Would you like to consider a birth control method that is better for you? Okay, and you can use this with the first example I gave you as well for Anna. You've clearly thought about this. And so what can I do to help you with this situation where you may want to get pregnant in the future, but it would not be a great idea for you to get pregnant right now. And so you may need a method for now, but you need something that you can, you need some time so that we can get your blood sugar under control so that you can get pregnant in the future and have a perfectly normal baby. So what doesn't work when it comes to counseling patients and when it comes to asking this question and waiting for the answer and dealing with the answer really is don't take sides in the patient's ambivalence. If she doesn't know what to do, don't take a side. Don't say, well, yeah, you really shouldn't be getting pregnant right now. That's not a good idea, or threatening bad outcomes, you'll get pregnant if you don't use a condom every time. This kind of stuff doesn't really work. It's not going to probably work with you. It doesn't work with me when people threaten like that, because most of the time I've sort of made up my decision. I need some information to make a better decision sometimes. And of course, giving advice all the time assumes that the patient doesn't know. A lot of times our patients know exactly what they want. It's a matter of clarifying what their values are and what they would like to do now. Okay, and then don't just keep offering idea after idea. It's always good to have patients think about what you're telling them and think about what they want to do. So this is what doesn't work when it comes to contraceptive counseling and for like prenatal messages and stuff. And it's basically taking sides in the patient's ambivalence. Well, it's like you really shouldn't get pregnant. You're right, when you said that you really shouldn't get pregnant right now because it would be really dangerous. It's like, she knows that, okay? And then you don't want to threaten bad outcomes. You'll get pregnant if you don't use a condom every single time. It's like when people do that to me and they're like, you really should, like when I always take the example of taking my car in, when was your last oil change? I'm like, 2 years ago? I don't know, ask my husband. And I'm always like, oh, and then they're like, well, you really should, you're going to destroy your engine. I'm like, oh God. I'm like, okay, just do it. Don't tell my husband, or whatever, So, I mean, it's just that idea of like, and then I want to like just shut him off and I'm not going to listen to it. It's going to be another 2 years before I change my oil. I'm sorry. I could care less about my car. So, and that's not a good thing, And then you don't want to always give a lot of advice. You just want to make suggestions, because giving advice, it really assumes that the person doesn't know. And a lot of our patients are they're probably much more savvy than I am about what they need to do to survive, okay? And then you don't want to offer one idea. Well, you if you're not using a condom, have you tried the pill? Oh no, I don't like pills. Well, have you tried the patch? Well, I don't really know what that is, and I'm not sure. Well, have you tried the ring? You know, and it's like boom, 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 and it's just they shut you off. It's not, you know, and you're not getting anywhere with them. So really asking about the reproductive life plan, that simple question, are you or your partner thinking to be pregnant within the next year? It's a great way for us to support the health of women. We want to make healthy babies. We want every pregnancy to be planned and wanted. And it's a great option to give our patients more choices. So the benefit to you really is by assessing and just supporting the patient, it reduces our frustration, and it gets us out of this idea of, oh my God, she's a non-compliant patient, she's driving me crazy. It's like, it's not my fault, you know, I haven't failed, okay? And it's like she's doing the best she can. You know, this reminds me of the depression screening. So a lot of people are doing the best that they can, and it's really important. And this is a personal thing for me. I learned at a very young age. I really need to not judge my patients on my own, you know, on the things that I feel that I do well. Okay, because if you were judging me on my oil change, you know, I wouldn't be that good at it. So. So taking the judgment out of it and putting the support back into it, and just basically, you know, just being friendly, asking these questions in a very conversational type of way is, I think, what really can bring some behavior change. When I've suggested for women that are in their 40s and are using condoms, when I've suggested, you know, an IUD, they're like, can you put one in me now? I mean, they're just like, why hasn't anybody thought of this? Can you do it now? And I'll bend over backwards to try to do it right then and there, if I can, and if they can use one and they haven't had unprotected sex and all that kind of stuff. But yeah, it's very important for us to understand that it's really a matter of supporting our patients making their own decisions. So really, we want to support the health of all women, okay? We want to make healthy babies, and we really want to give women choices of what they want to do. So thank you for joining me, and I hope you enjoyed this. My information is here on the slides. If you would like to get in touch with me, please don't hesitate to email me. I would be happy to give you more information or how we can order stuff for your patients, you know, that they can take home, and educational materials and things like that. Thank you.